Fall risk is a major component of a discharge counseling strategy for patients who are newly being started on any anticoagulant, including the DOACs. And it's sort of inherent that if someone's on an anticoagulant and they are at risk for fall, that you might even consider not giving them a DOAC or warfarin because of that increased risk for a major bleed if they do suffer a fall. There are some studies, though, looking at the rates of major bleeds in people who did have a fall risk versus patients who did not have a fall risk. And some of those studies have actually found that you were at no more likely of major bleed risk if you were also at a fall risk than a patient who was not at fall risk. Many people were interested in the availability of a direct and rapid-acting specific reversal agents for the DOACs, which some considered to be a weakness of those drugs when they first came onto the market. And yet their use increased over the years despite the absence of a specific reversing agent. So I think the availability of a reversing agent is really very specific to a couple of environments that some people are glad to have it for, but in the usual scenario, we've been using these agents with increasing regularity even in the absence of a reversing agent. The two major reasons that you would consider using a rapid-acting specific reversing agent for a DOAC would be one, either a major life-threatening bleed that you couldn't control through other mechanisms, or the urgent need for a procedure that has a high bleeding risk associated with it that you don't want to delay the procedure, and then you would use the reversing agent so you could more immediately go perform that procedure. We still need to improve our use of anticoagulants, and so I think there are a lot of unmet needs that need addressing. If as many as half of patients who should be on anticoagulation aren't receiving it, I think we need to have better strategies for identifying those people. There's also data that people who are at least originally started on an anticoagulant do not necessarily stay on that anticoagulant down the road. A lot of people self-terminate or discontinue their own therapy. So I think patient compliance strategies is going to be an important component in the future too. There are a variety of things that are being investigated looking at the future of stroke prevention in non-valvular AFib. There are atrial appendage closure devices. I'm a pharmacist, so that's a little bit out of my realm, but I know that continues to be an area of study. Other strategies for stroke prevention in AFib would include ablation procedures to terminate AFib completely. I think those are improving, but probably not yet where we like them to be. And then certainly the identification and better management of patients with atrial fibrillation who are on anticoagulation to receive the maximum benefit for those people. Another area that I think there's research in, and there's a little bit published, but I think we need more data, is the appropriate efficacy and safety for patients who are stented, who receive coronary stents, but also have atrial fibrillation. And we historically have treated those people with the respective therapies, both antiplatelet drugs that are called for with the stent, and then full anticoagulation for the atrial fibrillation. And is it possible to identify a safer strategy than using all three that still keeps stents open and prevents stroke and atrial fibrillation so we can minimize bleeding and maximize efficacy without necessarily having to use all three agents at the same time?